can, okay, let's see, I can make you presenter. Let me see if I can record this.
Okay, move this out of the way, blow this up. Hopefully that's somewhat filling your screen. Can you guys see that?
Yeah.
Okay, good. So this was a case that finally got a CT. He'd been sick for about a month, actually, about 5 weeks. Had gone into urgent care in the ER, had chest x-rays which showed kind of patchy opacities, was diagnosed or suspected having COVID. Over the month, he had 4 negative COVID tests. And a couple things you can see that are a little bit atypical for COVID are, even though later in disease things vary, but he does have some pretty plump lymph nodes, and the parenchymal findings are also atypical. So, the ground glass, that's fine, but there's a lot of kind of areas of these kind of fuzzy ground glass nodules in a lot of areas. I kind of see them up in these areas here. So as you know, we've all seen an increase of this, and some of us been texting each other saying, hey, we've seen another case. This guy, after denying it multiple times, finally admitted that he had been vaping more marijuana every day since being quarantined, and really started heavily about the time that his symptoms started. So, and important to note that this was read when this guy came in the ED, this was read as COVID. And again, he was put in isolation and everything, and had another COVID test, and I think they even bronched him because all the other tests were negative. And this was a case of EVALI. I have to see, I can't remember if they specifically got oil red O macrophages off of the bronch, but they started them on steroids and almost immediately got better, both on imaging as well as clinically. So just a case of EVALI masking as COVID.
Case of anchoring bias.
What?
It's a case of anchoring bias.
Yeah. This is just one of these, these are just interesting cases. These slow flow vascular malformations I find very, very interesting. So there's all these different criteria about how to define these things, hemangiomas, vascular malformations, high flow vascular malformations, slow flow vascular malformations. This is a slow flow vascular malformation. They often have anomalous drainages, large drainages to central vessels. So you can see here, the brachiocephalic, there's this anomalous drainage of this vascular malformation into it. Vascular malformations are also, especially the slow flow ones, are likely to have phleboliths, like this one here, as well as this one over here, which is separate and also has a drainage. This one has a drainage. It's harder to see. Let me see if I can find it. Also directly into the vein. I haven't looked at this in a couple of days, but here it is. You can see it kind of this direct drainage into the central vein. Also has a lot of phleboliths. The interesting thing is there's also air in this because they injected the patient. So air from the injection got into the vascular malformations. And there's also presumably other vascular malformations. Let me reset this. Down lower here, all this kind of tortuous stuff, if you follow it up, it drains into, kind of goes up and has these other little calcifications. So presumably another venous malformation. And these often have some, and then, another one maybe back here. So these are, acquired at birth. These are not like hemangiomas, I think, you don't have them at birth, but they grow over time. These are, you're born with these. And these are pretty much asymptomatic. The high flow vascular malformations, which have more arterial supply, can be quite damaging and have a lot of issues. The slow flow ones aren't a big deal, but and the important thing is not to touch it. Don't biopsy it. Don't just leave it alone. Don't mess with it. You know, the IR people hate dealing with these, especially in their extremities, because they have to treat them over and over and over again. They're a real pain in the butt to treat if they're associated with some sort of blushing or other issues. So I like that case. This case,
I could imagine somebody mistaking that for a teratoma.
Teratoma or a thyroid something.
Yeah.
Or and putting in, and actually one of a very, good colleague of mine said, just, take a second look, confirm this is a vascular malformation, because he was wondering if it was something else. And you definitely don't want to put a needle in it. So this is,
sorry, do they have like a genetic malformation, like Parks-Weber syndrome or something like that?
This patient or in general?
The prior patient, yeah.
No, there's no history. 78 years old, coming in because she fell. So she got a full trauma pan scan. So no history of anything. And honestly, the cases I've seen like that have the three I've seen the past 3 or 4 years have all been older patients with completely incidental asymptomatic findings. Whereas the high flow ones that have the arterial supply, those usually come in with issues of failure of some form.
Yeah, we don't see many here, but I imagine that would be good for a time-resolved MRA sequence if you guys have it, so you can see the inflow and outflow.
Well, the problem is with those is they have extraordinarily. I showed a case a couple of years ago where I knew the patient had one, and she was an older woman, so I wasn't super concerned about radiation, although I scanned her at 80 kV. But I did 5 scans. I did non-con, arterial, immediate delay, venous, and then like a 3-minute phase. So if you're going to do with these, the flow in these is it's not like an arterial. I mean, those things light up really quick. These things, they can enhance, their max enhancement could be towards the 2-minute mark.
That's why I said MRA, time resolved MRA.
No, I know, but so you would have to run your time resolved MRA really long, because most time resolved MRAs are meant for about 30-second perfusion or 25-second perfusion. If you're going to do that, you would need to increase your the time of your scan really, really long. But we
go out to about 1.5 minutes. But what we do is each acquisition, we do like 30 acquisitions. They're like 5 seconds each. And so some of them end up being really bad in terms of respiratory motion, but the patient kind of like intermittently holds their breath. And so like every like 5 or so sequences, you end up with a good phase.
Yeah, no, and I have some with MRAs, evals, and it is definitely a way to go. If you need to confirm that's the diagnosis, definitely. This is a patient who has a lot of issues. You can see that there's some pretty tight tracheal stenosis. That's a pretty tight trachea there. A lot of just calcification. This guy's been trached 100 times. And also has presumably a floppy trachea here, some tracheomalacia. So this is an interesting, and then obviously the marked hyperinflation, and hyperinflation, not really emphysematous change, it's just marked hyperinflation. And this is maybe some minimal emphysematous change, but I wouldn't really call, like up here, but I wouldn't really call most of this emphysema. But he has a history. This is a 20-something-year-old with severe developmental delay that had bronchopulmonary dysplasia. And I haven't seen a lot of bronchopulmonary dysplasia in adults. I always thought there was a lot more scarring than small airway abnormality. I don't know if you guys have seen a lot of adults with this, because the really impressive thing here is obviously the small airway. Beyond the trachea, to me, is the small airway abnormality. Jeff, any of you guys have experience with bronchopulmonary dysplasia in adults or coming across cases of people who survive into adulthood?
So, Seth, I would concur with that. The cases I've been shown that were called bronchopulmonary dysplasia by our pediatric radiologists, but who had grown up and we're now getting imaging that I was seeing, they all looked like Swire James to me. So what I really saw was air traffic. I saw small airways disease. I didn't see a lot of scarring.
Okay, so you've seen cases that look like this?
Yes.
Okay,
Well,
good.
Although yours is better than mine, you know, got more air trapping than my case. But
Yeah, because I was just looking up his history, and it said, you know, bronchopulmonary dysplasia as an infant, born at 6 months, in the hospital for, you know, the first year of his life, very sick. And who knows? You're right. I mean, maybe he had repeated infections when he had was in the hospital for the first year of his life, and that's the cause of this. In addition to bronchopulmonary dysplasia,
well, you know, I think the terminology is misleading because dysplasia implies that it's a congenital lesion, some problem in the way things were formed. But I really think it's an acquired lesion, and you know, it's from all that time in the ICU. That could definitely lead to airways disease. The fact that he gets bronchopulmonary dysplasia makes you think it's something congenital. It's not really.
oh, it's not a congenital lesion. I always thought it was a congenital. Okay.
No, I think that's just unfortunate terminology. There's a lot of bad terminology in pediatric radiology.
Yeah, that's a good point, because bronchopulmonary dysplasia is just from being in the ICU and intubated for a lot. Yeah, I had never really thought about it, but it's not a congenital thing. Yeah, and that's a nice tracheal stenosis there.
Yeah, I mean, that's real. I can't believe he's not trached or isn't trached now, but I'm sure he's been trached many times given what this looks like up here. And then one last case, which is, I was shocked when it was a low number 2 on my differential. Let's see if you guys, what you would think of this. Let me go up higher. So I saw this. This is a 17-year-old coming in with cough and fever. And I really thought this was going to be, and you can see there's some kind of cystic, multiloculated. I really thought this was going to be a CPAM or, I don't know, one of those things. But given its location, I said, you know, maybe a bronchogenic cyst that got infected and kind of, but given its extent up here, I thought it was kind of odd. But this was a bronchogenic cyst. Was taken out. And the surgeon said, oh, it's bronchogenic cyst. And I was like, yeah, right. We'll wait till pathology comes back. And pathology came back and they're like, nope, bronchogenic cyst. There were signs that had been infected, which is probably the cause of this kind of contour up here and kind of the involvement of the parenchyma. But this was just a nasty looking bronchogenic cyst. Down here, that fits, definitely. But when it, you know, I really thought it was getting into the parenchyma, I was thinking it would be an infected CPAM or just a CPAM. Yeah.
And no blood vessel going to it. No,
it wasn't a sequestration. Yeah, no, looked for all that. Wasn't a sequestration. Nope.
It's not one of those hybrid lesions.
Yeah, I thought it was totally going to be a congenital lung malformation, but it was not. It was an foregut duplication abnormality. All right, those are my cases.
Great. Who wants to go next? I think Jeff's having PACS and clinical issues. David, do you have anything this week, or?
Well, I did, but I might still be able to mobilize it here, but I got interrupted by construction going all around me with hammers and nails flying. Okay.
Peter or Brian?
I got a couple. So this is a companion case to assess. This is a 4-month-old with congenital diaphragmatic hernia, and I find that there's a lot of overlap.
Vascular opacity concerning for pneumonia. Whoops, sorry.
That's fine. I find there's a lot of overlap between what's reported as BPD and the sequela of this. So you can see this is a pretty bad CDH. Here's the left lung. All of this is abdominal contents, and this was a CT at like 4 months of age. And what you can see, there is some fibrosis within the walls of these kind of like enlarged abnormal air spaces, and there's also quite a bit of air trapping. To my reading, my reading of the literature about this, it's a combination, at least for this entity, of congenital, because the lung was arrested at development in utero, and then also postnatal exposure to PEEP and high FiO2 in the ICU and things like that. This kid had a quantitative VQ scan showing that the right lung received 90% of the airflow. Then I thought this was just a kind of a cute case. So this guy came in for a biopsy. I biopsied the solid part of this nodule here. That came back as adenocarcinoma. And there's this round ground glass thing in the superior segment of the right lower lobe. And I thought it was nice on the sagittal. It shows it a little bit better that I think they're probably related. That this adenocarcinoma is probably going across the major fissure. And what ordinarily I think I would want to just call it an atypical adenomatous hyperplasia. I think this might be a mucinous metastasis from direct spread of the right upper lobe mass. This was a case I saw.
Can you go back to that for a second? I'm not sold on it being a direct spread. I think it's probably somebody that just happens to have two adenocarcinomas that are nearby.
Yeah.
I mean, it's hard to know, but
Yeah, that's what I was thinking. It would just be two separate primaries.
You don't see it? Okay. Yeah. No. Possible. Yeah. They're going to try and wedge out the soup segments when they go to resect the right upper lobe. So either way, bucket lesion. This lesion incidental on a TAVR. You can see a membrane in the left atrium. And it's incomplete. So this is a core triatriatum sinister with a fairly large fenestration, just incidental, picked up at 76. Interestingly, she had a TTE the day before, and no report of that on the TTE, but probably not hemodynamically relevant. So it does separate the left atrium to the two chambers, one where the pulmonary veins drain, and then to the left atrial appendage, but there's a pretty large fenestration between the two. This was kind of a fun case. This is a 16-year-old teenage girl with hyper-eosinophilic syndrome with peripheral blood smear showing that, and also a liver and muscle biopsies showing that as well. And what we can see here on the delayed postgads, there's a non-ischemic pattern of subendocardial and midmyocardial and apical enhancement of the RV. Let me show you that on the short axis. Go. Sorry, it's mostly subendocardial in the RV. What was interesting, so we still, we're hopefully getting a coil upgrade, but we still do T1 FATSAT because we can't do T1 mapping. And so this is a T1 FATSAT post-contrast. And I think it nicely shows the two of the different populations of this, or stages of this disease. The first stage is the acute necrotic stage, which I think you can see here in the septum pretty well. And then the apical anterior wall of the LV. Here's the T2 FATSAT that goes along with that. So there's a myocardial hyperemia and edema involving those areas, but no delayed postgad enhancements, or not, at least nothing convincing. And then the delayed postgad enhancement involving the RV is the with this what looks like on the Fiesta sequence as a small apical thrombus involving the RV. That's the thrombotic necrotic stage. And then later on, if this gets big enough, it can progress to the late fibrotic stage where there's synechia that prevent the ventricle from contracting normally. But just a nice example that shows the first two stages of the disease process.
Is that thrombus or is that chemical shift?
Yeah, I wasn't sure entirely.
Right there, it looks like a chemical shift artifact.
It could be we have kind of like a thick slice images, like 8 to 10 millimeters, and they went back and did a second look echo, and they thought it looked more like a thrombus on the echo.
Can you show the 4-chamber delay? Because a 4-chamber delay should just be a big black hole.
Yeah, it didn't show up well on that.
And there it's white,
it
which
like
makes
fat.
me think that's fat.
Yeah, you think it's fat?
It looks like it's between.
Yeah,
the
because on your PSIR, the bright's going to be fat and the dark's going to be fluid. So that's just a ball of fat.
Okay, it's not a PSIR. It's just it's a triple.
Is that it's a PSIR or is that a mag? Looks like a PSIR.
No, we don't have the ability to do PSIR.
Then it's either fluid or fat, but it's something. Yeah. Thrombus is going to be pitch black.
Yeah.
Yeah, I think that looks like.
Yeah, it's not in the lumen either. It looks like it's between the ventricles.
Yep, it could be. Like I said, they when they went back and looked at the echo, there was a mobile echogenic immobile echogenic mass at the RV apex. That was 18 by 8 millimeters. So I think you guys could be entirely right. It could just be artifact, but I wasn't sure. And then this last case, this is a guy with 3 years of follow-up. So the bottom one is 2017, the top one is 2020, and this is a biopsy-proven nodular amyloid with an AL light chain amyloid. You can see multiple bilateral pulmonary nodules and masses. The one in the right lower lobe is partially calcified.
Now is when David is supposed to chime in and say that it's ossification.
It's ossification.
Yeah, and then so pretty much unchanged over 3 years. Cool. Those are my cases.
Yeah. Great. Peter, do you have anything?
I don't have anything this week.
David?
Travis, I've got my packs working. I can show a few.
Okay, sure.
All right. And I'll jump back.
You got control?
All right. You guys see a radiograph? Nope, they see the wrong. Let's see here. How do I do this? I hate this no GoTo meeting. I still can't figure out how to. Let's see. How? There. Let's try that, and then try again. I'll just share this all. I'll just share the screen. All right. You guys see a radiograph?
Yes.
All right.
Yep.
This is a 15-year-old with shortness of breath, and this is the initial chest radiograph. And I think for a 15-year-old, his heart looks a little on the plump side, and you might see a few septal lines out here, but not a ton going on there. But he presented rather quickly short of breath, and this is his subsequent radiograph, and you can see he's already on ECMO at this time, and there's a lot more diffuse lung abnormality, left lower lobe collapse. But let me show you the CT that occurred in the interim between these two, and you can see we've got, let me make it bigger. We've got basal septal thickening, small effusions, sort of a patchy ground glass opacity. And then on top of that, we've got a really dilated right atrium, right ventricle. And if we window, we can see the RV is pretty thick looking. Pulmonary arteries are big centrally, and he's got some lymph node enlargement and small pericardial effusion. So, echo showed severe right heart dysfunction and findings of pulmonary hypertension. And you put it all together, this is a great look for pulmonary veno-occlusive disease, rapidly progressive pulmonary hypertension, small left atrium, pleural effusion, septal lines. He was also did very poorly on vasodilators, which he was given initially before. So they did a right heart cath, which confirmed, I don't know the pressures, but it was very elevated right heart pressure. what normal wedge pressure, so all consistent with PVOD and rapidly progressive. No known cause. It can be idiopathic, or you see it with connective tissue disease, but it is a previously healthy individual. And now this is the radiograph you can see requiring ECMO. So I don't have tissue confirmation, but I don't have a better differential diagnosis.
Is the vasodilators what sent him over the edge? I've seen that before.
Yeah,
like people
it's
come
unclear. I don't know. It was a consult of a consult, if you know what I mean.
Yeah, because they're okay, and then someone says, "Oh, they have pulmonary hypertension. Let's give them, vasodilator,"
Yeah,
and then they just frickin' tank, because that's like the last thing you want.
Right, they require that driving pressure.
Yeah.
I don't know. It was a consult of a consult. So, but yeah, this is a really good look for this. But yeah, underlying cause, don't know. And of course, at this point, a biopsy isn't going to really help. And furthermore, the patient's too sick for a biopsy. So that's presumed PVOD case. Here's another interesting case. This is a younger patient. I got to go back in time here. But at one point had a CT scan. I think this is the older scans, older, thicker slices, breast shields, but has this funny thing in the left lower lobe. You can see there's some septal lines, and then there's this nodular stuff. And if you look at it, it's water attenuation. It kind of seems to be associated with the diaphragm, and these vessels pass right through that. And this was done at St. Elsewhere, I don't know how long ago. It's been a while. And eventually the patient shows up on my radar for follow-up of nodules, and she's now in her 20s. And you can see it looks pretty similar. You've got all these septal lines and these nodular areas that on the right window settings are actually water attenuation. So I think this is just a funny lymphatic malformation of the lung. So I consider it a do not touch. It hasn't changed in over a decade, and it's involving the lymphatics, and the water attenuation areas to me look like they're probably, here's the soft tissue. Yeah, there they are. You can see how low attenuation they are, but a good look for a lymphatic malformation. I don't know if anybody has any other thoughts, but that's all I could come up with.
The left inferior pulmonary vein was okay.
Yeah, it's right there.
Have her get a lobectomy so we can find out.
Yeah, that's not going to happen. This is kind of a crazy case. So this was a line placement, and you can see a catheter sitting here over a wire. And initially, I thought this was a right IJ approach, and their catheter was sort of just past the skin because they're having trouble with their guide wire, and you can see it does a loop-de-loop in the SVC, and then it makes this hook here in the right ventricle. But it turns out actually this was a left IJ approach, and their catheter, this was for hemodialysis catheter, and you can see it follows the guide wire, but it goes across the brachiocephalic up on the right, up the IJ, loops back around, then makes a loop again in the SVC and comes in there. So this is just a little, and they couldn't get the wire out. I was worried with this little hook there that it had lodged in the myocardium, or worse, had perforated the RV myocardium. But he went to the angio suite, and the interventional radiologist was able to gently coax this out and remove the wire and then put a line in appropriately. So, but it's not too often we see guide wires in, and I've not seen one do this in a long time. I'm not quite sure how one would even do this, why it forms a loop here. It doesn't make any sense to me. Other than the patient's had sternotomy, and I don't know if they've had previous lines and there's a stenosis or something. We never got any cross-sectional imaging because we didn't need it really. Weird. Okay. And then this is a kind of an interesting case. This is a 70-year-old patient who has a history of pancreatitis and has this really nasty, you can see abscess around the pancreas, but also this one just sort of filling the left upper abdomen. You can see it's in the peritoneum. There's the retroperitoneal fat. It's all encasing the spleen. But if you follow it, you can see it tracking along the esophagogastric junction here, and then goes up. And you see this funny collection here, which on initial glance I could see easily mistaken for a very abnormal esophagus, but this should give you pause because there's not a defined muscular wall. And more importantly, you can actually see the collapsed esophagus right there in front of it. So this is just an extension of a peri-pancreatic abscess into the lower mediastinum, sort of in a posterior esophageal distribution, and just all part of the same. And then we had on a different scan, just seeing this was a arterial phase in the pulmonary, but you can see it's pretty bad, but nice collapsed esophagus there, and a sagittal view can show it pretty nicely as well. But just we've seen a couple pseudocysts extending up in there. This is more of an abscess at this point. So, but it's one of the pathways from the abdomen into the chest, and this is along the diaphragmatic hiatus.
So at this point, it's a pseudocyst.
Yeah, I guess so. And then
Tom showed a case of pseudocyst that extended all the way to the right paratracheal part of the mediastinum.
Yeah, they can be quite impressive. All right, and then I'm curious if you guys have ever seen this. So one of the abdominal imagers I work with asked me if I had ever seen this before. This was just an incidental detected abnormality. Is this right here on this abdominal CT is right at the RV apex. There's this little outpouching, and we only see it on a few slices. So it's clearly intrapericardial, and it looks, I can make let's see, probably a sagittal best. But it kind of looks like a little RV apical pseudo-aneurysm. Let's see, where did the heart go? There it is, right there. Have you guys ever seen one of these?
I've seen left ventricular like congenital diverticula. I guess it could happen on the right too. What do you think, Seth?
Yeah, the question is it a little pseudo-aneurysm, or do you think it's just a congenital thing? As far as I know, the patients had no instrumentation, no cardiac history.
I've been fooled once by a small pericardial hemangioma, but in this location. But that's weird. Why don't they get a chest study? That's
they're going
cardiac
to
study.
get an echo.
What is the echo? Said it connected?
I don't know. They haven't gotten the echo. This was just I don't know yet. That's the next step. Because I don't know. To me, it looks like it is in continuity, but that's interesting. I never hemangioma. That's one I haven't thought about.
No, I have a couple cases of small pericardial hemangiomas from the ARP that look like that, and I've seen one that fooled me, but it was more anterior to the right ventricle, and I called it a pseudo-aneurysm, and it was a hemangioma.
Yeah, it looks like there's continuity right in here.
How does it look on a coronal, Jeff?
Let's go anterior. There it is right there. See, I think there's a little, I'll blow it up and move it.
Because there it looks like it's separate on that one image.
It seems to, it's got undercut margins against the RV.
It's hard to tell. Yeah, it's hard to tell. I mean, it probably connects, and it's probably just some weird outpouching, but yeah. I don't know.
I don't know what to make of it. I told him I didn't know what it was, other than that's what it might be. It was a little diverticulum, and I have no idea what one does with them.
Could it be ARVD if it is real?
I think it's just another hemangioma. I've seen a ton of those, and they're boring. So I think you're trying to make something interesting out of a boring case. That was a joke.
It's interesting.
Yeah. All right. Well, that's what I have this week.
All right, I can show some here. If I can figure out how to use the interface. There we go. Make presenter. Share screen. Okay, I actually pulled this one up just from my server while we were talking. This is one I showed a few years ago, but this is a young patient who had pancreatitis and had this remnant of a pseudocyst, except this remnant of the pseudocyst, communicated up along the esophagus, much like Jeff's. Has a few different little pockets here, and this is one that went all the way up to the aortic arch and just above, so it almost made it to the thoracic inlet. But this is the longest extending one I have seen. Certainly not as large in the axial plane as Jeff had shown, but of course, anything we see there, it's always important to check and make sure it's not continuous with something below the diaphragm. All right, this is an interesting case, and this is a 76-year-old man, and this is from an outside hospital where he had the original workup, and you can see he has a right hilar abnormality here. You can see this mass-like opacity there, and it certainly fits over the right hilum on the lateral view as well. So he had several CTs, and this dated back to last year, the workup. And he actually had 3 biopsies at the outside hospital. They did a transbronchial biopsy, a CT-guided percutaneous biopsy, and a surgical lung biopsy, all of which were non-diagnostic. So he came to us with the question, could this be Castleman's disease? Because that was kind of their diagnosis of exclusion. I'm curious what anyone else thinks about Castleman's for something that looks this ugly, but I was not very excited about that diagnosis at all. You can see it's a very irregular, if not frankly spiculated thing that is exerting mass effect on the right upper lobe bronchus, also on the bronchus intermedius. You see there's a little bit of a divot here.
Do you have a contrast enhanced scan that shows just dramatic arterial enhancement?
That shaggy, Travis. It's always very well defined.
So that's what we said, you know, get a contrast enhanced CT next time. And this may be,
yeah, I would have just said cancer.
Yeah, exactly. So this guy got presented at tumor board. They were like, there's no way, this has got to be cancer. You know, this looks nothing like Castleman's disease. I don't care how many negative biopsies you've had. I mean, it's behaving like cancer. Long story short, they ended up getting a PET first, and I don't even have to show the fuse, but I'll just show you too. This thing has SUVs of like over 20 in some areas. So certainly, again, not behaving like Castleman's disease. And I think this was another case, at least initially, of anchoring bias, because it had been billed as Castleman's. And by the time this got a little delayed during the whole COVID time, but this is the most recent study. He came in with hemoptysis, and you can see this thing is indenting, if not frankly invading into the airway. And here was the picture from the bronchoscopy. So this is the right upper lobe bronchus up north. This is the bronchus intermedius. And so this turned out to be just a squamous cell carcinoma. So the pathology on it wasn't as interesting, but it is interesting that they had 3 negative biopsies on the outside.
You said squamous?
Yeah, it was a squamous cell. So, which I think fits with something getting this large without actually metastasizing anywhere else. But certainly really no features going for Castleman's other than they hadn't come up with another diagnosis. And his age, I don't know if I've ever seen Castleman's in someone that old. Have you guys?
We did a paper on it from the AFIP stuff, and it's various age, but they don't look like that. They're rounded balls, basically.
Right.
Avidly enhancing rounded balls of, you know,
not irregular.
Not spiculated with looks like lymphatic spread out.
Anyways, yeah. But I think that's a good point too. Yeah, when if it doesn't have typical features, then it doesn't matter how many negative biopsies they've had. Okay, let me show. So I'm going to revisit this. So this is the case I showed last month, and I'll pull it up again because I have more information now. So this was the radiograph from last year. And then this one is the one from now. I gotta get this thing out of the way. And you can see, so this is a young patient who has Marfan's, who had a aortic valve, ascending aorta repair, and had a stent graft in the aortic arch. And this is a radiograph I saw and noticed this extra convexity. And he had been admitted with presumptive endocarditis because he was bacteremic. He had some B symptoms, persistent fevers, whatnot. I heard that, was worried about this being an abscess around the graft or an infected graft. And this was the old CT, and then I'll show the new CT on this side. And so long story short, this was one I showed, looked like it was going to be an infection. They did an indium labeled white blood cell scan, which was negative. There was no uptake here. So they thought maybe it's just perigraft fluid because he had some before, even though it's clearly getting bigger and there's some inflammation and some lymph nodes. So they sent him home on antibiotics. This was end of April. And then I'll pull up the more recent one. And we will see now that he wasn't getting any better. And you can see this thing has enlarged more, and it's even extending into the suprasternal notch right here. You know, there's no, he had a debranching here. There's no disruption of the graft itself. And this time they actually did a PET, and you'll see that in this case, the PET is really metabolically active here. And so this finally convinced them to do a little bit more intervention. I don't know, I mean, I don't know how you treat it. I've always read that bacteremia in the setting of a foreign body is infection, you know, endocarditis or graft infection until proven otherwise. But they sample, our interventional colleagues sampled this under ultrasound guidance. So this is suprasternal notch. That's that fluid collection I'm showing you. They're just trying to prove that that has no flow in it. And then there is their needle right in this. And they
stuck a needle in that? Wow.
Yeah. And they, well, this is the thing, right? The surgeon was like, after the original study, last time I presented this, I said that they were not convinced, that they were a little bit in denial that the fluid collection had
Wait, can you go back to the CT? Where the hell did they stick their needle that they didn't think they could kill this guy? Like, that's...
So it's in that suprasternal notch. Here, I'll pull it up right here.
I'm sorry, I was kind of like looking at a study I have on my list. I didn't...
Right here.
Oh, that... Well, damn, that's still... Wow. Yeah, that's still pretty...
Yeah, but yeah, I think the brachiocephalic vein is probably this. These are some of the graft, but this was all pus, and so they actually just went to the OR yesterday, debrided this. They didn't replace the graft, but they put a bunch of Vanc and whatever other antibiotic beads around it. But yeah, they, you know, again, this was not enough information for the surgeons. They wanted confirmation that it was infected. So yeah, but so false negative Indian labeled white blood cell scan. I know we talked about it before. I think David had mentioned, and I discussed it with our nuclear medicine folks, that, you know, nobody really knows the sensitivity of them, but certainly abnormal fixation of the white cells can happen, or I don't know what happened in this case, but still the pretest probability was high enough and the suspicion high enough that got to keep working these up. And then I'll just show one more. This is...
And Travis, I do have a case to show.
Great. Okay, I'll show this one. So this is a guy with prostate cancer. And if you look at this, at first you might think there's some degree of left upper lobe collapse, but there's no real luxical. There's not a lot of volume loss. There's no shift of the trachea. You can see on the lateral, there's zero findings that would make you think of left upper lobe collapse. And it looks like this thing maybe more posteriorly, in fact, either posterior segment of the left upper lobe or maybe subseg of the lower lobe. And actually, I showed you, this was, they were able to get an old radiograph from 4 years prior and showing that this had been there. So you're thinking it's probably something, you know, benign, be it acquired or congenital. And I think, you know, unlike Seth's case of the bronchogenic cyst, you know, this is all branching tubular things. So they all look like airways, and there's overinflated portions of this left upper lobe as well. And when you look at the airway branching pattern, it's really a bizarre left lung branching pattern. You know, here's this left upper lobe bronchus, but it's kind of, I don't know, you don't really get this may be lingula, and then this is all, I think, just from superior segment of the lower lobe, like I said, that may be all overinflated and mucus impacted. So I think this is probably a bronchial atresia. I mean, I guess it could be acquired. I'm not sure what you guys think. I mean, certainly not prostate cancer metastasis, and not really anything for them to worry about. It was just, you know, just weird configuration of his fissures that made it hard to figure out what exactly this was. But certainly no obstructing endobronchial lesion. There's just mucus-filled stuff here. I'll show it. I'll try and show it better on a sagittal. Oops, wrong way.
But Travis, that air trapping part is not downstream from this cystic looking part, is it?
No, and that's right. And that's the thing that's confusing about this, right? Or one of the things that's confusing. And like, what is this?
Mm-hmm.
It's like, yeah, I mean, I don't know if it's congenital or acquired or
That anterior
what
stuff
it is.
looks is so cleanly defined. There's no obstructed bronchus going to it and stuff like that.
Well, the anterior part looks like a bronchial atresia. Here's an impacted bronchus right here. You know, and it just, but it kind of goes, because you can see this is that mucus impacted bronchus there. This was just a really confusing lesion. I mean, it's more of an academic discussion at this point, but I don't know what it is, especially with these weird airways and stuff back here.
I like this being some sort of a combo congenital thing.
Yeah. So not as clear cut as, well, Seth's wasn't clear cut either, because we thought it was going to be a CPAM, but yeah, I don't know. Just an interesting congenital thing. But I think there was some initial fear that there could be a mass that was, you know, could be metastatic prostate cancer. And that's why the patient was referred to us. But obviously this is not, none of this looks like cancer. It all looks like dilated mucus impacted airways, small vessels going to these areas. I mean, there's certainly a long-standing, if not congenital, component to this. And we'll never know because they're not going to touch it. So, all right, those are my cases. I will stop sharing and see if we can give control to David here.
So I just want to emphasize that, you know, appearances to the contrary, Travis and I are not in cahoots about arranging cases. So all the time that Travis was going, you know, well, all the time there was discussion of Castleman's disease, I was downloading a case that turns out to be Castleman's disease. So I want you to know this is not prearranged. But here's a 32-year-old woman with this mediastinal mass. And she had 2 outside CT scans, one without contrast here, showing this well-defined mediastinal lymphadenopathy, very homogeneous mass, and then with contrast, this dense opacification of the entire mass, rather uniform. And this was, as you would expect, a Highland vascular Castleman's disease.
Yeah, that's that's a nice classic look.
But this is the case that you guys were talking about earlier and didn't quite have, but here it is. So something caused me to download this case this morning, and it must have been you guys getting ready for conference.
I mean, I've seen like one case, 2. I've seen a lot of, you know, it's interesting because they say the, you know, unifocal form is much more common. But man, I've seen a lot, maybe it's just where I've worked, Baltimore and here, that I've seen a lot more multicentric disease, you know, associated with the Kaposi sarcoma virus and so on and so forth. But they say that this is more common, the unifocal form.
Yeah.
I think it must be patient selection bias, because
I think it is. Yeah, as I'm saying, a lot more.
I mean, I can't even think of, I've probably seen less than 5 cases of the multicentric.
You've seen more of the unifocal?
Yeah.
Okay, yeah, I've seen like 1 or 2 unifocals, and I've seen a whole ton of the multicentric. But I agree. I mean, that all the literature says the unifocal is more common.
So Travis, let me or Seth, actually, let me tell you a little anecdote about Don Resnick. When you said that you should recommend that Jeff's patient have surgery so you could find out what that lower lobe water-filled presumed lymphatic abnormality really was.
Facetiously, of course, but yes.
You were facetious, but Don Resnick was the bone radiologist who was just starting his career when I was a resident in San Diego at your place. And Resnick was famous for the correlations that he made between the radiology and autopsy specimens. So he would flag patients that he saw as part of his practice who had interesting joint findings. And then these were mostly BA patients, so they were older, and a number of them, you know, did die, and some of them went to autopsy for varying reasons. And so he would always have very good correlation with autopsy specimens, he worked with a pathologist who helped him, prepare these very nice specimen radiographs that he could compare with the findings in the same person when living. So he did very good pathology. So one patient that he was following didn't show up for a clinic visit. And so he had the fellow on bone radiology call, and the patient made the phone, the doctor made the phone call to the patient's family, and they said, "Oh, unfortunately, Mr. So-and-so died, and so that's why he didn't come for his appointment in the rheumatology clinic." And Resnick also facetiously said to the fellow, says, "Ask her where he's buried." So I just want you to know there's precedent for your, pseudo.
Yes. Nice. Must be the San Diego charm wearing off on me.
That's right.
All right, guys.
All right.
Thank you.
Good.
Thanks, everyone.
Thanks,
All right.
Everyone, see you next week.
Thanks, Travis.